Afternoon. Chris Ip is my name, and Surgical Registrar from Melbourne, Australia. Thank you very much for the opportunity to present on this work alongside our collaborators from Sydney. I have nothing to disclose. Primary bladder neck obstruction is a well-recognised but poorly understood cause for functional bladder obstruction in young adults. The diagnosis is made on video urodynamics and characterised by inadequate bladder neck opening during voiding without any anatomical obstruction. The current treatment strategies are really to reduce the bladder outlet resistance, including the use of alpha blockers, clean intermittent catheterization, and transurethral bladder neck incision. However, there's some emerging data in terms of supporting the use of Botox injection to the bladder neck. The largest prospective study was reported by Emilia Sacco's group in 2013, and they reported in 30 men with primary bladder neck obstruction, which were refractory to alpha blockers. And in their series, 80% of these patients had a good subjective outcome at 2 months, which slowly tapered down to 10% by 12 months. Interestingly enough, in their post-treatment questionnaire, 80% of men also wanted repeat treatments, but that wasn't studied at the time. So the aim of our study was really to explore the role of Botox injection further in terms of whether repeat injections were effective in treatments for patients with primary bladder neck obstruction. We performed a retrospective chart review from May 2011 to 2017 in the two centres. Primary bladder neck obstruction was diagnosed on video urodynamics, and each patient received at least one injection of Botox. We found 13 patients in total, 5 men and 8 women with this diagnosis. The median age was 42, one patient was lost to follow-up, and 69% had previous exposure to alpha blocker therapy. Here are results. On the right, we have a graph that shows the journey of our patients, and we found that 75% actually had a good subjective response at the 4 to 6 week mark after their first injection. Of those who didn't have inadequate responses, all of these were women, and that was quite a surprising result. In total, 7 patients had repeat injections, including one patient who had a dose escalation up to 200 units after the 3rd injection. In total, 3 patients had converted to transurethral bladder neck incision, and all had complete resolution of their symptoms. In terms of patient safety, only one patient complained about transient retrograde ejaculation, and no patients complained of any significant stress urinary incontinence. So in summing up, we conclude that the repeat injections of Botox appears to be safe with minimal complications, at least in this small case series, with good subjective response that's comparable to what's in the current literature. All of the men responded, and that was a surprising result. But I think this is still early stage in terms of this research space, but it might appear to be a role for Botox injection for patients in whom retrograde ejaculation is a particular concern. However, given the limited size of this study, further studies are recommended. Thank you for your attention.
Yes, questions from the audience?
Thanks for that, Chris. Nice study. I'm interested in the length of time that it took between patients coming back for their repeat treatments, because my understanding is in skeletal muscle, botulinum toxin works for only 3 to 4 months. That's what we see with the neuropathic patient. Was that because of a constraint from the hospital, or because it really did take that long for their symptoms to recur?
I think that's an interesting question. It's a bit hard to say on a retrospective chart review in terms of how long the duration of the Botox actually lasted for. We did see from the Sacco study that about 10% still had reasonable subjective response up to 12 months. So that might be part to do with it. The other issue is perhaps it's getting in and having that procedure done in a timely fashion. Thank you.
But just for clarification, when you inject in the bladder neck, you're not injecting by the skeletal muscle. It's also smooth muscle, so it should not be much different compared to the detrusor. Yeah, but I understood you injected in the internal sphincter.
Yeah, so the area of injection was targeted at the bladder neck, which is,
Right.
I think the technique describes about a centimetre away from the rim of the bladder neck.
Okay.
Janelle Brennan, my question for you, actually I have two, but I don't remember the second one. The first one's about whether you did EMG at the time of FUDS. Did you do that?
Only one patient had EMG at the time of FUDS in all our studies.
Because ultimately, I agree with Sharon. I think we might think we're putting in the smooth muscle, but there's definitely spread of toxin. And I wonder if the patients who responded and didn't respond were what sort of pelvic floor dysfunction they had rather than a pure primary bladder outlet obstruction. The second question, which has just come to me, I do a few of these, and I'm interested to know, did you look at your complication rates? Because the thing that women complain about is not really stress incontinence, it's flatus incontinence. Did you, and you know why that should be, but it just happens often. Did you look at those risks in your study?
That's a very interesting comment. I didn't come across any flatus incontinence from the chart reviews, I must say. But yeah, we'll take that on board for future studies. Thanks.
Okay, thank you very much.